Hi everyone. Welcome to another webinar where we go through a few cases. I know, like Dan said, it is Halloween, so I do appreciate that you guys could have been trick or treating, getting some free chocolates and sweets or whatever else people people do on Halloween. So what we'll do is I'm going to share my screen, and like we said already, I will take questions. So there's quite a Q&As and there's a webinar chat. So just feel free. Normally, I do manage to keep track of like the questions that come in. So try, just feel free to ask whatever you want. So hopefully everyone's got access to cases. Just click on that link that we've just shared to everyone, and we'll go for case number one. And we actually do have polls that will come up as well. So if you guys want to, you can take a little bit, you can get a bit more involved and actually tell us, what you think the answer is and stuff like that. So this is the first case. We're going to go straight to the plain film. And for those that don't know, do click on the cloud button, which is over here in this corner, and that will enable you to be able to actually download the cases temporarily, and you'll be able to have a kind of slightly smoother use of the actual platform. So what we see here is, by the way, just feel free to throw in whatever you think this could be. So what we have here, what's going on? So we've got an abdominal film. We don't have the entire abdomen, but actually, thankfully, what we've done is taken two halves of the abdomen. So we've got the upper abdomen and the lower abdomen. So feel free to answer that poll that's just come up. And so if you have a look at it, you'll try and figure out what it is. Is it a sigmoid volvulus, a cecal volvulus, an incarcerated hernia, or an incarnation hernia? You get the little thing to Halloween. So yeah, we've got a few answers coming in, and at first it can be quite difficult to tell actually, because we don't have the entire abdomen on this particular plain X-ray, right? So you have to kind of let me just get rid of that. So what you have to do is just sort of try and figure out what is actually happening from basics. So first off, we're looking at an abdominal film, and we can see there are multiple loops of dilated bowel within this abdominal film, right? So is this large bowel or is this small bowel? So these look like haustra. Can you see these? But they don't go all the way across. So therefore, this wouldn't be in keeping with small bowel. Is more likely to be in keeping with large bowel. Some of it actually seems a bit featureless. So you kind of feel like you've got this big sort of area over here, and there's not much in the way of any like lines or any sort of haustra going between there at all. Now, if we go to this lower one, you can actually start to feel as though actually, yeah, you know what, this is feels like it's coming from the pelvis and it's kind of going upwards and upwards, upwards in that sort of general direction towards the right upper abdomen. And so that's actually pretty much what you'd be describing with what people have essentially said this to be a sigmoid volvulus, which would be different from a cecal volvulus, where it pretty much does the opposite and goes the other way. Now, the thing with the sigmoid volvulus is that you are generally looking for that classic sign of a like a coffee bean sign. And it's not always visible on an X-ray, but you can sometimes see it. And when you do get it, it can be really, really not nice for the patient, obviously, but it does look like a coffee bean, like the ones you'd see in Starbucks. Now, what we have is the CT scan, right? And then what we can do is have a look at what it looks like on a CT. So this CT scan isn't the best of CT scans, I have to admit. Don't tell the radiographers. You've got to try and maybe window a little bit. Yeah. And then that kind of works a bit better, doesn't it? So we go from the top, and it looks like it's a contrast enhanced study. And for those that can't tell, you look at the aorta and see whether it's slightly brighter. If it's as bright as the bone, then you start thinking, okay, this must be an arterial image. This is not quite as bright as the bone. And actually, when you look at the portal vein, which is probably somewhere squeezed around here, and you compare the two, that one to that one, this one looks a bit brighter, doesn't it? So therefore, this must be a portovenous image. Now, as we scroll, you can straight away see that, yeah, there's loads of this dilated bowel, right? And again, you can see that these lines that go across. On this one, it does look like it goes all the way, but this one doesn't go all the way. And plus, it's sort of more on the peripheral, the outside of the abdomen. And so this can be really daunting when you're first doing on calls and you're not entirely sure what's going on. You think, oh, there's so much like dilated bowel. So the key thing is to do is go for the common things first. So generally, I would go all the way down to the hernial orifices and make sure that there's no sort of outpouching of bowel. Then I'd go all the way down to here, looking for any obturator hernias, because that'd be an easy win. And genuinely, after doing that, then I'd be looking for a sigmoid or a cecal volvulus. And the best way to do that is probably just to use the MPRs. And as you scroll through, you'll hopefully this works. We scroll through, you'll see a little twisting of the bowel. So if you keep your eyes over in this area over here, can you see that? And what I'll do is I'll kind of go forwards and backwards. And you can see kind of twist. see it do like this and like that, right? And that little twist is pretty much that the volvulus. That's where it kind of twists on itself, and then you get that sort of obstruction. See, it goes like that, and then back again, and it's like a whirlpool sign. That's genuinely what they would call it, like a whirlpool sign. And so now you pretty much know that this is a sigmoid. This is a sigmoid volvulus, right? So the next thing is like, what do you actually do with the sigmoid volvulus? So generally, you need to decompress it. You'd be putting in a flatus tube, but there can be situations where things have actually got worse. So you'd be looking for ischemia. You're looking for a perforation. You'd be looking for that kind of thing. And now I pointed out that swirl. Can you see it? So if we go sigmoid colon here, you can feel like a little bit of twist, and then there's like kind of pouching here, and then it goes out like this. And then it becomes very, very dilated afterwards. And so that's what it looks like on CT. And so whenever you see any dilated bowel, go for what I've said. First things first, go for the hernial orifices. Then you go for the, once you've done the hernial orifices, go straight through into the, look for any sort of hernias anywhere else in the body, and then just go for a sigmoid volvulus. And by doing that, and what you need to do is just do the corona views and just have a look for that whirling sign. If you haven't done that, then just have another look at the whirling sign on the axial views, and you feel like you can see it just around there. Now, here you do actually have hernias, by the way, for anyone that wants to know. You've got a hernia there and a hernia there. And the thing about this hernia is that these look like they contain fluid, but they don't contain any bowel, because look, this kind of goes there and then it just sort of disappears. You get a bit of bowel, but it doesn't look like it's poking through. So these are hernias, and they are hernias with some intra-pelvic fat, I guess, and a bit of fluid, but nothing more than that in this, and nothing more than that. So there's no complications secondary to that. So don't fall for that. And in truth, I have fallen for that, where I've gone for the hernial orifices thinking it's an obstruction, but actually obstruction is far further proximal to where I thought it was. So it's just very important that you really look at the hernias. If you've got a hernia, make sure that there's definitely bowel going in and out, and there's definitely dilatation, like pre going into the hernia in the first place. Right. So no questions from what I can see so far.